Good morning, colleagues. Good morning, colleagues. Good morning, colleagues. If I could just encourage everyone just to take a seat, we'll just get started in a moment or two. Thank you very much. Thank you so much. Good morning and welcome to this fantastic event, the Scottish Patient Safety Programme National Learning Event. Such an important event and such a lovely opportunity, isn't it, to just come back together again and to be able to talk, to share and to learn together. And on this critical topic of creating the conditions for safe care. We've got some really exciting opportunities today. Oh, so I'm just going to check that. Moving forward. Sorry, James, I'm just clicker. Hey, so it's always that good start, isn't it? It's that moment. It makes all the clinical stuff look easy. So I'm Professor Jan Gardner, I'm NHS Lanarkshire's Chief Executive, and I'm really delighted to be able to be here to facilitate and chair some of this session this morning. In preparation, I was doing a little bit of reading back because I think we spend so much of our time out in boards at the moment in that place of, I guess we've come from a place of almost fibrillation and actually starting to recover again from what has been the toughest journey. Back in 2020, none of us could have imagined anything that could come like the pandemic, and we thought it would be the hardest change and I guess response that any of us would need to have done. But actually, I think where we are today actually probably makes that pale into almost never insignificance, but into a lesser element, because recovery is so much more challenging, and all of the different elements, the creating the conditions for success, are so important. And I think all of us, every single one of us, needs that oxygen in our everyday life of knowing that we're coming to do something good, to make a difference, and that the patients that we serve go away having had a better experience and better care, and indeed the experience for our staff is also better and a good outcome. I think the significant changes that have come across the landscape during that time, of course, as well in the context of the clinical issues that we've had, is also the changes in our demographics. And I was just saying to a few colleagues this morning, I think we're just at the foothills of really understanding the legacy of the pandemic, both in terms of our society and directly onto our patients and our staff. So today we have the challenges of trying to come back to look at all of the marginal gains, that are the opportunities in our system to do the right thing every time. But also that's within a backdrop of a workforce that has changed. The experience that left our system is significant, and I think sometimes we forget to acknowledge that. And so we need to build our capacity and indeed our capability. And learning events like this are so incredibly important. We're also against a backdrop of workforce challenges, and every single one of us came into these careers because we had a passion to make things better for the people that we serve. But bringing people into health and care now isn't quite as straightforward as it used to be, and so our workforce challenges are significant. And I think events like this and the work of SPSP sitting at the very heart, at the very core of what we do, is really critical, because it gives us that common purpose, it gives us a way of coming together, and it gives us a way of moving forward with power and indeed with a really positive impact for our patients and, say, for our staff as well. So great opportunities lie ahead. And actually, again, looking at Audit Scotland's report that came out just earlier this year, talking about all of these different elements, as well, of course, as the financial challenges. It is the perfect storm, the workforce challenges and the performance challenges. And performance, I always feel that actually we have to do the asterisks after performance to say that performance, every number is really just a person, it's an experience, it's a care episode, and it's an outcome that matters in many, many lives. But coming back to those elements is tricky. But SPSP has sat and having a central role for the last 15 years. And I think for all of us who have grown up with SPSP, as the way that we do things is really lovely, that this will help us be the beacon of hope for how we grow and build our strength going forward. Today we've got a really great opportunity and we're going to hear from a number of speakers. I'm delighted to see so many people in the room, and for me this is my old stomping ground of Jubilee, so it's lovely to be back here as well. But it's great to have people in the room, and I believe many hundreds more online, so welcome to all of you online as well. We want this to be a participative event. There will be Q&A sessions, there will be Slido, and I'll be encouraging you in a moment or two to make sure that you have got Slido on your phone and that you interact, because I think that opportunity right in the live space to see and hear what people are thinking is so important. In terms of the housekeeping elements, if I can ask people to turn off their cameras in the virtual audience. Again, just noting here, and I'll note again, but we will be recording this event, and indeed there'll be photography during the day. Again, I think probably never more important, again, to just get that message out that the energy is building and that together we are moving forward. Coming straight into the housekeeping, for those of you who maybe haven't been able to join already, if you need Wi-Fi, it is the Golden Jubilee Conference Hotel public Wi-Fi that you can join. This fantastic event has clearly been put together with an enormous amount of work, and I would really commend all of those organising, Jo and her team, for all the fabulous work. And those wearing the yellow lanyards are the people to see today. If you need some help, they are the people with the answers. There isn't a fire alarm planned today, so if you hear a fire alarm, then please proceed to the nearest exit. During the plenary sessions, as you would expect, let's get our mobiles to silent. And again, I just note the piece around the photography and recording. On your tables, you'll see some microphones. These are really, really effective, particularly for people who are online. And even if you feel that actually you may be able to hear in the room, I would really encourage you. They are mobile, so they can be moved around the table. Don't worry about moving them on the table, but they mean that those of our colleagues joining online will have a really clear sound of your voice and your question. And we'll be picking up questions, as I say, from the virtual audience and then in the room as well. A small ask for me personally, you may have seen in information that came out around the allergy piece. It's me. I spent many years as a clinician wearing latex gloves and unfortunately have a very severe anaphylactic problem now with bananas and mangoes. So if any of you have brought those lovely things today, if you wouldn't mind keeping them in the bag, I would be very grateful, so my EpiPen can stay in the same place. So we don't want any of those demo events today as part of the scenario, so thank you. In terms of the aims of the day, it's to explore the organisation and the system-wide conditions. I think these system-wide changes and system recovery is so important in terms of that supporting the safe delivery of care. As I said already, the SPSP essentials sit at the very core, but it's about making sure that I guess we take the time. In these times, we have time to think and hear and reflect about, are we doing everything we can to harness the support that is there and the opportunities that exist. And really critically, and I can't overemphasise that, it is that forum for leadership, for teams to come together, for us to interact as human beings, both in the room and online, to be able to share with colleagues. We've got a really great agenda. You'll have seen that in your pack, and again, a lot of opportunity to hear from a number of different people across the board, and also a lot of effort to bring all these people together. We've had a slight change to our programme, and so Dominique Bird is now joining us as the Deputy Director and Head of Quality Improvement in place of John, who had to unfortunately step out, but I'll speak more about our panel as we go forward. It's great to have all of the boards represented today. It's really, really fantastic. And actually, it was lovely for me to meet a colleague from Lanarkshire. Quite dreadful that I'm coming to a national event before we've met, but we will meet again in Lanarkshire. So great to have all the boards here, and of course, our health and social care partners as well. We are just one joined up system, and I think that is more and more important as we go forward. We have now got the digital delegate bag, so I think a great idea, moving away from the old delegate bags of the past, and with the QR code you can see all of the information if you don't already have it to hand. We're really interested in your feedback from today, getting it right and making this an engaging opportunity to come together, and a good learning experience is important, and so that feedback is really important. And so through the day we'll be capturing your views on different elements and indeed asking for your feedback. So please join at Slido. The Slido piece, again, if I can just note in terms of Slido on your phones, I'm hoping that you all have already downloaded, but if you don't have it before, can I ask you and invite you now just to make yourself familiar with Slido, because that will be the place where you'll be putting in your answers and we'll be able to aggregate views as we go through the day. Okay, so without further ado though, I would like to pass on, we have our MSP Jenny Minto, the Minister for Public Health and Women's Health, who will now give some opening remarks. Thank you.
First of all, I apologise that I cannot be there with you today, but I was keen to provide this message for you all. I would like to thank Healthcare Improvement Scotland for their work in organising this event today. I do not underestimate the amount of work that goes into gathering people together, both virtually and in the room, supporting us all to talk and, importantly, to listen to each other. It is wonderful that so many have been so keen to take part today, and to know that so many people from across the health and social care sector are gathered to discuss how we can continue to deliver safe care and to become even better at doing so. As you will know, better than anyone, the delivery of safe care for everyone all the time needs to be a focus in every part of our system, in every corner of our country. Most importantly, I would like to take this opportunity to thank all of you attending for the work you have done and continue to do to make health and care in Scotland safer. The ongoing success of the Scottish Patient Safety Programme and the associated strands of work is a testament to your hard work and the work of your colleagues across the country to improve care for some of those people who are most at risk. Never has that been more important or more apparent than now. You and the other committed professionals you work with every day have kept a focus on safe care during some of the most difficult times of our lives. You have made a life-saving difference, so a huge thank you to you all. In my role as Minister for Public Health and Women's Health, I recognise the paramount importance of safe care. When people need to access any part of the health and care system in Scotland, they must have confidence that they will receive treatment that is effective, person-centred and safe. The Scottish Patient Safety Programme has been vital to achieving this ever since it was first started. When it was launched in 2008, it was the first programme of its kind anywhere in the world. Over the last 15 years, it has delivered improvements in areas ranging from cardiac arrest to stillbirth to sepsis, to name but a few. When I think what that improvement means to patients and their loved ones in deaths avoided and lives saved by the hard work of you and your colleagues, on their behalf, I would like to thank you. More recently, 7 acute hospitals across Scotland are demonstrating improvement in at least one outcome measure related to either recognition and response to deteriorating patients or reducing inpatient falls. This is just one example of many, and it is down to the hard work and dedication of you and your colleagues. The Scottish Patient Safety Programme continues to be vital, probably more now than it ever has been before. Your focus on patient safety has been crucial over the last few years in providing the environment and the conditions that enabled NHS Scotland to be flexible and adapt quickly to the greatest challenge our healthcare system has ever faced. The focus we all place on patient safety did not stop during the pandemic. Now, as we emerge from that intense couple of years and faced a host of different challenges, the continued revitalisation of Scottish Patient Safety Programme and our concentration on patient safety more broadly is critical. The future of the Scottish Patient Safety Programme is incredibly exciting. No doubt it will be the subject of many valuable and interesting conversations throughout today's event. But we know there is still more to do to continue to improve safety. As a key component of the Scottish Patient Safety Programme, Essentials of Safe Care focuses on person-centred systems and behaviours with the aim of enabling the delivery of safe care for every person within every system, every time. It highlights the need for safe communication within and between teams, safe and consistent clinical and care processes, and leadership to promote a culture of safety for all. By bringing together these key facets, the basic foundations are created to support the further work on safety. One of the aims of today's event is to explore the organisational and system-wide conditions that enable the safe delivery of care amidst increasing system pressures. In order for our healthcare system to be as safe as possible, we need to be able to identify where the concerns of individual patients may point to a wider pattern. For too long, patients have sometimes found it hard to be heard when they have concerns about the safety of their care. And the Independent Medicines and Medical Devices Safety Review from Baroness Cumberledge clearly told us that there have been times when, while individual concerns have been listened to, they have been considered as one-off complaints rather than being indicative of a wider safety issue. That is why it is so welcome that the focus of today's event is on the system-wide conditions for safe care, and why I'm delighted to say that we are approaching the final part of the parliamentary process in establishing a Patient Safety Commissioner for Scotland. This role will promote and improve safety by developing a system-wide view of healthcare and using that insight to identify safety issues. The Commissioner will have an important role in bringing organisations together to take action on patients' concerns. They will work with existing organisations and healthcare professionals to enhance coordination across the healthcare landscape with the aim of promoting improvement. They will complement the vital work being led through the Scottish Patient Safety Programme and being done by you and your teams, rather than duplicating patient safety work and systems that are already there. And most importantly, considering the theme for World Patient Safety Day this year, the Commissioner will listen to patients' experience. They will amplify the patient voice and advocate for patients to be listened to, driving positive change and making healthcare safer for us all. Creating a Patient Safety Commissioner for Scotland is a step that has been very widely welcomed, and I am grateful for the support I have received from across the patient safety landscape for the establishment of the Commissioner. I have every confidence that this is the right thing to do and will enhance the strong foundation we already have in Scotland on patient safety. I know that you will be keen to get on with the day's agenda, so please allow me to say one last thing before I wrap up. I am so sorry that I'm not able to join you in person today, but I continue to be encouraged and excited about what the future of safe care in Scotland holds. As you continue to share and integrate your learning during this event, know that you are all working together to deliver safe care for everyone, all of the time. I'm sorry that I will miss Penny Pereira and Dr. John Boulton presenting on the Creating the Conditions for Safe Care. I hope you enjoy the event and the many interesting discussions that you will have. Thank you.
Thank you very much, Minister Minto. Before we move on, I just want to give a little update on the fire alarm situation. Joe just very helpfully said that is actually going to be a fire alarm test. So before I empty the room with the test, just to let you know that will happen between 11 and 3. But if there is a full fire alarm, obviously, to evacuate. So then if we can move on in the programme, we're about to hear from Joanne Matthews, or Jo, our Associate Director for Improvement at Health Improvement Scotland, and of course the architect of today's event. I think, again, before I pass on, the next sessions are going to be all about us having that engagement, hearing from our speakers, and indeed having the discussion around this critical work. And also, I should have noted earlier that this afternoon we also have the very exciting launch of the Paediatric National Programme as well. So a really fantastic day. But without further ado, Joanne, if I could ask you to come up, and look forward to hearing your talk.
Good morning, everybody, and I would just like to extend that welcome from Jan to everybody here in a not so sunny Clydebank this morning, but also to the hundreds of people online who are joining us virtually from all over the country and actually beyond. So many of you will know that I always start my presentations with this slide. You've heard the Minister just reiterate the importance of a focus on system-wide safety across health and care in Scotland. So to ground us in this, we do have to come back to the why, connecting those hearts and minds into why we are doing this. Why does this remain as important now as it did when we embarked on that SPSP journey some 15 years ago? And why does this actually matter to you? What's brought you here today? And ultimately, why SPSP? What can it do to help you? Professor James Reason is a well-known psychologist who contributed significantly to the field of safety. And most of you will know him for his Swiss cheese model of accident causation. And if you don't, I would suggest that you have a good look at it because it's an excellent piece. In 1997, he published this book, Managing the Risks of Organisational Accidents, where he described safety as a continually emerging property of a complex system. This year has marked my 10th anniversary as leading the Scottish Patient Safety Programme. And my goodness, how our context has changed, how our system has changed, how our range of methods has changed, alongside the people that have come along with us through this journey. And that context mirrors that constantly evolving nature of safety that Reason described. There's no doubt the last few years have presented significant challenges for health and social care. They have brought about a renewed focus on safety, but they've also brought to light some new areas on which we have to place priorities on. From the challenge of sustaining safe care right down to the actual bare essentials of what that looks like. And despite everybody's best efforts, harm does continue to happen. But the vast majority of people do come to work, as we know, to do the very best that they can. However, we know that there are also some, thankfully, extremely rare instances where this is not the case, such as the recent tragic events following Lucy Letby. In the context of our health and care system and how that now operates, we need to think differently about safety. And there's a clear need to build on those past gains, nurture the innovations that I see happening right across Scotland, and embed improvements that are being made. But the continual threats to safety within our complex system make that single cause and looking for that single cause a fantasy. All modern approaches to safety require continual adjustment, resilience, adaptation, and within that local context. And the most important cultural characteristics are having the right, not only just about having the right technical features, but also are organisations that are full of people that can sense, change, adapt, and change again to whatever that emergent challenge is, whatever that changing terrain looks like in relation to safety. And that has to be done supported by leaders. Because if you think about it, and you think about what James Reason said, that sense of a safer system is one that is never the same twice. And that reflects that continually emerging complex property that he described. So this is our first test of Slido. As we now operate within this new context, We want to explore, what does your organisation feel like in creating those conditions for safe care? How's it feeling just now? Is it purely a process? Does it feel owned by everybody? Is it a system of continuous learning, moving from reactive to proactive? How are you using your information? Is it with curiosity, dialogue, daylight and reflection? What we're going to do now is, if you can open your Slido and choose which number and which area reflects what you feel your system is looking like just now. So if you're struggling to get in, sometimes it's easy to use the QR code and it'll take you directly there. So it's certainly looking like we have some variation there, and there is clearly some work to be done, but positive to see that there are systems in place and that these systems are being able to manage and respond. But we definitely look like, from a cultural perspective, we have much work to be done across Scotland. And to do this, we need to start with looking at ourselves. Don Berwick described the pursuit of safety within this Health Foundation publication back in 2015 as volunteerism. He went on to say, and I'm going to quote, "It's more about what people choose to do than about what they require to do. Safety cannot, in a meaningful sense, be required of a workforce, or for that matter, of those they serve. For leaders, this means that their job is continually to try to build on and support intrinsic motivation." Now, you may agree or disagree with his reflections. However, we know that improving the safety of health and care is blooming hard work. And it requires us to have that intrinsic motivation every day to keep driving towards that goal. But it's also about what's in the circle of our control. What can we affect change? And what can we affect and influence within that circle of influence? So my next Slido, why are you here today? What's brought you here? What are you aiming to actually get out of today? Is it to learn, to share, to build, to network? Take a moment to use Slido to just pop in a couple of words just to describe what's brought you here today and what you're aiming to get out of it. Fantastic to see at the heart of that, the learning, the connecting, that sharing, which is exactly what the aim of our sessions are today. And I ask, as you go through your sessions, keep reminding yourself of why you've come here today, and can keep connecting that back, hearts and minds. Healthcare Improvement Scotland has been leading the national efforts to accelerate safety, reaffirming this commitment and focus within our recently published 5-year strategy, Leading Quality Healthcare for Scotland, which you'll hear more about from Simon later on this afternoon. A central part of this has and continues to be the Scottish Patient Safety Programme, a national quality improvement programme that brings people together, just like we are today, around a common purpose and a shared goal, improving the safety of care for all. Work that is of value and meaning, not only necessary to improve safety, but important for those that are at the heart of the change. The core themes provide a framework and a rhythm in which we create the conditions in which safe care can be delivered, systematically apply quality improvement methods to key safety issues, learn through iterative cycles of change, and share that learning across networks, blending the technical and the relational aspects of improvement through the programme. The foundation of this rests within the essentials of safe care, and without the ability to affect these, we wouldn't be able to make any of the improvements that you're achieving and you're going to hear about over the course of today. For those learning about the essentials for the first time, you'll be able to find all the resources within your virtual delegate bag, and that includes an interactive driver diagram which shows the 4 primary drivers which underpin the delivery of safe care, and alongside that the secondary drivers that provide the rationale for why these are important, the tools and resources, and a range of tools to support you on that journey to understand where you are in relation to the essentials of safe care. As you'll see from the breakout sessions today, the essentials of safe care has been woven through every part of the programme, and it's how we build that systematic approach to getting that foundation in place. But it requires organisational support to do this, not just only at a strategic but at an operational level with a constancy of focus. Last September, the Health Foundation published its evaluation and key learning from a partnership between Virginia Mason and 5 NHS trusts in England, who were trying to build cultures of improvement within their organisation. The evaluation found that a culture of peer learning and knowledge sharing was a critical enabler to that organisational-wide improvement. And that's where SPSP can also come in, creating those conditions in which that knowledge, experience and learning can facilitate and accelerate change and improvement right across Scotland. And throughout this learning session today, you can connect with teams across many different parts of the country doing similar work to you and learn from them. None of this work would happen without you and your teams, and that learning system supports the opportunities to share and improve. And I do want to come back to the why. Why SPSP? Because it works. As the Minister stated earlier, through your hard work and collaboration with the SPSP teams, we are now starting to see improvements in a range of different areas. When you consider the challenges that acute hospitals have faced over the last 3 years, we will shortly have a downward shift in the national falls rate, a fantastic achievement. And when you start to break that further, there are 7 acute hospitals that are showing significant reductions in their falls rate of up to 22%. And here is NHS Lanarkshire and NHS Borders and the improvements that they're making. But alongside that, there are 4 hospitals who are demonstrating up to a 33% reduction in falls with harm. That's really significant. Also delighted to say that through the work to reduce cardiac arrest, through the reliable recognition and structured response to deterioration, we have some significant changes in a number of boards, Lothian and Tayside, just examples here to share with you of how your teams are making significant impact within SPSP. But I also want to flag, when you consider these improvements from a patient, staff and system level, this goes beyond improving that single domain of safety, far beyond it to all aspects of quality. So again, I would ask, why would we not continue to focus on safety? So you've heard from the Minister, you've heard from Jan reflecting on the context within our system at this moment in time. You've explored why you're here today, and I've shared why SPSP can support. So let's hear from your colleagues.
I think patient safety is invaluably important because it acts as a vehicle that kind of overarches, makes sure that staff, people, boards are able to provide care very, very safely, and not just safely, but reliably, consistently, so that the best outcomes are gotten for the people of Scotland.
I would have to say patient safety is at the heart of everything we do. Every healthcare professional I've ever met, at the heart of everything we do is about caring for people. And if you can't keep them safe, you can't care for them properly.
Patient safety is fundamental to delivering high quality, good, safe care. And described patient safety as a discipline. And a cornerstone of that discipline is continuous improvement and learning from adverse events and learning from when things don't go well.
For me as a senior charge nurse in adult acute admissions, patient safety is really important to me. It's really important that patients in our care receive a really high standard of care on the ward. But it's also really important to me that patients have a good experience of care, and a focus on patient safety enables that. And it's also important for me as a senior charge nurse that staff have a good experience, and a focus on patient safety enables staff to use their skills and their experience and to really feel like they're doing their jobs and that they're providing good care for patients.
Our team have been involved with the patient safety programme for many years. Our improvement and our safety agenda is embedded from the patient safety programme. It's got roots in it. We use the structure of the SPSP, we use the improvement quality management approach all the way through. SPSP allows us to do that. It allows us to understand our own system and then pull from a structured approach, evidence-based, with experts nationally all across Scotland and England when needed. We can pull from global experts in SPSP.
Being part of the Scottish Patient Safety Team allows us to educate ourselves through the way that other health boards are working also. Look at the outcomes of things that we're doing within different health boards and see the aims that we are hoping to reach are being reached. So if another place is doing it better, getting better outcomes, how are they doing that? And then we can implement that within our health board to make sure that our patients are getting the best care.
It's also given us a sort of look at the journey through Scottish Patient Safety Programme. It's helped us to understand what that is. I think you can hear about it but not actually see what in real time it does and the impact that it has on the ward along with patients and staff as a team. So it's allowed us to be part of that journey and that process and actually feel good about what we do, what we've achieved and see outcomes, see positive outcomes for patients and be creative around those observations and how we manage them.
I'm always a strong advocate to recommend people get signed up to anything that they offer because you can guarantee you're going to learn a lot, you're going to improve patient safety, you're going to improve patient care, and you're definitely going to have a great time with a very, very knowledgeable team.
As part of the team, I've got to say it's a family. It's a family right across the whole of Scotland, and our ability to share information in a safe space and learn and develop safe systems absolutely encourages, develops and promotes patient safety, but also the development of our teams and critical thinking in complex environments.
And I'm going to leave you on Eddie's last point. SPSP is a family and we collectively are working together to improve the quality and safety of care across Scotland. Really looking forward to continue to work with you on this. I hope you have a fantastic day. Thank you very much.
Thank you so much, and absolutely inspirational, and just I feel, I'm sure as all of you do, uplifted in energy hearing both Jo, your comments and also those of our colleagues across Scotland. We're now going to move on to our next session, which is about how to keep safety central to what we do and how to create those conditions for safe care. We've got two speakers this morning. In a moment, I'm going to pass over to Pereira, who is the Q Managing Director. And I have to say, apart from being an incredibly well-accomplished individual, must have the coolest job title I've ever heard. I think that's just a fantastic job title to have. So Penny comes from the Health Foundation, of course, and before that she worked at Newham University Healthcare NHS Trust in East London, and she was Director of Strategy and Service Improvement, and again comes from a career in service improvement. Following Penny, we have a new speaker. We have Dominique Bird instead of John Bolton, who is the Deputy Director and Head of Quality Improvement at Cymru, and she will be giving us a presentation, again leading on the same topic. Dominic leads up on supporting the organisation there to build the learning systems, so very similar to the work that is being done here in SPSP. Again, is bringing through the safe care partnerships that is being pioneered in Wales, and so it's really helpful, I think, to both today be thinking about our own system learning and all of those really positive reflections, I think, again, that are very uplifting, but also to hear from colleagues right across the UK in the different approaches that they're taking. So without further ado, over to Penny. Thank you. Penny, I'm not sure if you can hear us, but you're on mute.
Forgive me, can you hear me now?
Yes, that's super now. Thank you very much.
Brilliant. Okay. Thank you. Well, there you go. Some of the downsides of not being able to be there in person. I wish I was, one of those awkward members of the family who ducks in and ducks out awkwardly. But yeah, fabulous to be here with you. I feel already energised by the message that I've been hearing, your kind of palpable commitment to learn and maintain action on safety. So Dom and I want to kind of use this session, a bit of a space to reflect further together on what it takes to keep safety central to our work. I guess I'm hearing all the time that's feeling a bit hard given the huge financial and operational pressures that are forcing difficult choices day in, day out for people. So I'm hoping this session can help us step back, think about how our approach to safety might need to evolve to match the world that we're currently in. I'll focus on two shifts that I think are needed to help keep safety really relevant, both in terms of the kind of major transformations in care that we're seeking and in terms of day-to-day delivery. I'll draw out what these shifts mean for those in this room and feed in a few examples and sources of support, just as an input to get us started in the conversation, in the Q&A and through the day. I know Dom's got some really great material to share, going deeper into work in Wales on the enabling essentials of safe care. These essentials feel like a great focus for your time and your work here, providing a constant even while the specific nature of the focus on safety may shift in the way that Jo was talking about. I'll be drawing on the work of the Health Foundation. So I had the privilege of leading the Foundation's safety work for several years. It's great to hear our work already quoted several times this morning. My role involved helping to embed what had been an explicit decade-long separate portfolio on safety into a broader approach for improving care, drawing on learning from the research, some of which we commissioned and the leading practice we saw across the UK. We promoted a shift from reactive to more proactive approaches to safety. It was really great to see how that synergises with what you were presenting on your approach just this now. Often Scotland, has been ahead of the curve on this. It was a real pleasure to work with Simon Watson, who was one of our 2 safety associates for the Foundation at the time. But looking across the UK, I guess we were concluding that the emphasis was too often only on looking back to count and react to incidents of care, squeezing out the time to proactively understand and anticipate risk. And I guess your Slido poll suggests that we're still on a journey in relation to that. I hope that general shift was important, that it was a valuable contribution to our work together. Looking back from the other side of COVID, I wonder whether we've gone far enough on this. You know, experience suggests incidents of harm aren't a good predictor of future patterns of risk. And I'm kind of wondering whether that applies at a macro level to the world we're in, as well as to specific areas of care. So through the Q community, which I lead, we've been convening the national leaders from all the countries of the UK and Ireland throughout the pandemic and since. Jo is a fabulous member of that group. They've been reflecting on how our strategies for improvement are evolving as we're tackling bigger, more systemic and interconnected challenges. The opportunity for the next stage of safety is arguably how we really engage proactively and positively with the safety implications of the strategic changes that we need in models of care. You know, for example, to have more online and preventative, patient-orientated services. I'm going to simplify this kind of shift into two changes that I've seen happening in recent years and that I think is going to be critical to safety being relevant to the future. I'd love to hear in the Q&A how far you agree and where you are in your approach. So the first shift is from focusing the majority of our attention and effort on individual hotspots where we know harm takes place to a more systemic and person-centred view. The kind of proud heritage of safety science and improvement has it's gained credibility and momentum by showing what's possible when you systematically analyse and address specific key sources of harm, which might otherwise have been accepted. Scotland's done amazing work in this. It was great to see some run charts already this morning reminding us of that. I don't know if it's visible to you, but from where I stand, I'm always seeing the rest of the UK looking to learn from the work you're doing in Scotland. The work you're doing to reduce infections, falls, pressure ulcers, deterioration of patients, your work on medicine safety, all of that work remains critical, particularly when in some areas we have lost ground through the pandemic. But the challenge is that this could continue to absorb all our available time and energy. We can't afford to do that if it draws us away from also taking a broader holistic view. With really important exceptions and recognising that I'm kind of much less well connected to this agenda than I was a few years ago, feels like the balance of investment and work across the UK and safety remains on the parts of the system that are most visible and often most in the political spotlight. There's good grounds to believe that when people are at their sickest in hospital, there will be particular risks that we need to address while people are in our care, in our home. But improving those areas that we have good data on, it can't be at the expense of a wider view of safety in terms of the balance of resources and attention. COVID gives us an example of this in terms of how we manage the immediate response to pressing challenges. I'm conscious I'm a little bit unsure of the pattern in Scotland, but in England, we manage COVID rates in hospital for a kind of critical period by moving or keeping people in care homes in a way that we realised actually led to tragic loss of life, and that was less visible than if we'd taken a system view. That was understandable, perhaps, in the intense immediate instability and sense-making of the early days of the pandemic, but I wonder whether that over-focus on acute care is part of an ongoing habit in healthcare. We need a broader view of safety to underpin the strategic transformation that we need to make for our health sector be sustainable. This image is taken from work in Scotland a few years back, part of your leading approach in tackling whole system flow. It's a topic I've had the privilege to publish on, looking across the UK and internationally, and would sometimes see that concerns about safety can hold back the shifts that the whole pathway view suggests are kind of necessary and possible. So unless people have collaborated and worked together between organisations, we continue to see that people are risk averse when it comes to transferring patients between services and sectors, not sure if they'll be safe. That's understandable, but if that ends up holding back a move to less hospital-centric services, then at what cost? Because that's going to be essential to meet the demands for care and ultimately avoid the greater harm if our health and care system struggles to cope. either for a few weeks over winter or longer term in the face of workforce and financial pressures. I'm drawing here on the work of Charles Vincent and René Amalberti, so published with open access, paid for by the Health Foundation before the pandemic. This book feels all the more relevant since. Beyond taking a healthcare system view, they explore the additional challenges and opportunities that become visible when we understand risk and harm, safety from a holistic person and population view. I'd love to hear if that kind of resonates, any examples of that perspective, and how it might be influencing your safety work in the Q&A. To me, it brings to mind work I've been able to follow in recent years on shifts to video consultations. While changes to more remote services bring new risks, we can only really weigh up and prioritise action to understand and address harm if we have a holistic view of patients and families and what's happening in their wider life as they decide whether and how to engage in healthcare appointments. We saw a big shift in people's thinking and action on this across the UK when the pandemic made face-to-face care impossible. In Scotland, I think your greater focus on kind of holistic co-production with those using services is marking out like your progress now. It feels like it's made it easier to transition to embed virtual care models as a long-term part of the mix once it was no longer, even once it was no longer the only option. So recognise still a way to go, but making a connection with that agenda here. Whether we're thinking from the view of an individual, an organisation, or a health system, this kind of holistic view points to the second shift from focusing on safety and isolation to a more integrated understanding of quality. Again, building on Joe's wise words. Feels like looking back over 20 plus years doing improvement now, I realised that actually if we'd taken a more holistic approach, it would have helped the sustainability and scaling of improvement work that I was involved in. Quite often we would have safety projects that would celebrate like the primary focus on safety, but even to the extent that we wouldn't mention the implications for efficiency or timeliness, for example, even when the changes we were introducing might well have positive potential benefits in other domains of quality. I can understand how we got there. The prevailing belief was that clinicians would engage best with safety as a priority, so we should focus wholly on that. Obviously, it remains true, people are particularly energised by improving safety, but a kind of narrow view may also have done us a disservice. When making changes, we need a kind of authentic, holistic assessment of what's needed. So understanding all of the implications of a particular change can help us have conversations that bring in everyone who needs to trust in and support a change if it's going to last. In a few weeks, we're going to be publishing a new Health Foundation long read that will be summarising the benefits of improvement across multiple domains, systematically thinking about changes from the perspective of, patients, the workforce, organisations and systems will be important to make the case for changes, especially when resources are so tight. A more rounded view helps improvement integrate into the mainstream work of organisations, where you kind of naturally need to look at work from all perspectives. So, that shift in safety supports the move to quality management systems, moving from safety projects to an integrated way of delivering. I'm really conscious I'm potentially telling you kind of what you already know. While this feels like a journey that has a way to go when I'm speaking to colleagues elsewhere, in Scotland, again, you're leading the way in articulating and supporting a quality management system approach. I'd be really interested to hear how that's feeling for your organisation now. This joined up approach is needed more than ever given the complex challenges of recovery. But I'm conscious it can be more challenging perhaps to keep on this course under pressure. I'm really looking forward to getting into the Q&A. Love to hear what you see as the main shifts and priorities to keep patient safety central. This feels like a time of fluidity and improvement in safety, so precisely the time for debate. Insofar as you think the diagnosis I've shared feels right, what might it mean for you? So I guess for the organisation and system leaders in the room, I think this is calling on you to frame improvement thinking and action holistically, whether that's when planning for long-term shifts in care or making operational choices day to day. Consider how to embed safety in a way that keeps it central and not just embed it in your team or organisation. We're going to need collective leadership and learning, recognising that safety risks will show up for patients and populations beyond our institutional walls. Safety and improvement practitioners that are here, the skills that you have are as critical as ever. So consider how far these skills and conversations extend. Either under pressure, take the bigger system view and think about what's needed to enable safety in a world of more community, home-based and virtual care. Let's get ahead of that. To do this, we need to make it as easy as possible to learn with others, as you bring safety specialist skills to integrated quality strategy. There's a role for leaders in helping you to do this, both your employers and organisations like his, the systematic learning, approach that, Joe was just outlining, it goes beyond what I see in other parts of the UK. Make use of it. It's a really precious set of supporting resources. Well, all of that is giving you a wealth of ways to connect and learn in your local area and in Scotland. I also just want to make sure that you clocked the opportunity that Q provides to make broader connections. Q complements what you have with the two-way learning with the wider improvement community across the UK and Ireland. Q offers free, flexible learning and development. It offers opportunities to bid for funding or take part in insight and innovation work, bringing together people to collaborate on particular topics. There are over 5,000 people in Q now. It's open to people with a wide range of skills and experience. Scotland's overrepresented by head of population, as you'd expect. If you haven't joined yet, please do consider it. There's a Q Scotland stand in the exhibition area, I understand. I hope you'll find in Q lots of learning, friendly peer support. There is a more complex landscape for those seeking improvement than at any point in my career, as people have already commented on this morning. It's at that time when it's more important than ever to help each other maintain focus on what's critical and work out how to flex our approaches. Things feel tough, but the Health Foundation has the luxury of being able to take the long view across the improvement movement. What I say is that we've adapted, we've responded with creativity and agility many times over the years. I'm really confident that we're going to rise to the kind of next stage of transformation that's needed. To bring us back to the particular focus of this event, while a lot can change around us in terms of the scope and ambition of our safety work, for both senior leaders and practitioners, one constant are the things that create the right enabling conditions for improving safety. I'm really looking forward to hearing what Dom has to share about the work in Wales and then getting into discussion about that. Thank you. Over to you, Dom, I think. It feels like I'm still in presenter mode, I think.
Bore da, morning from Wales. Sorry about that, Penny. I just can't do two things at once. So I had to load my slides then and focus on that bit. So they should be loading up at the moment. And thank you. It's great to be with you and to hear about the work this morning, and also to build off Penny's fantastic learning and experience shared there. It's going to be a very similar picture, I think, that I'll be talking through in Wales. I think one of the key aspects that we have learnt coming out of the pandemic is around the contextual changes. How do we support in a different context, but also around focusing on those enabling pieces. So while my slides are loading, I'll just give you a little bit of background. My name is Dom Bird. I'm Deputy Director and Head of Quality Improvement in Improvement Cymru. So we are the National Improvement Agency for NHS Wales. Pre-pandemic, some of you may have come across us in previous lives as the 1,000 Lives improvement teams. And we focused very much historically on topic-based improvement programmes with separate sort of improvement capability support by one of our partner organisations. Now, those all aspects came together, and really coming out of the pandemic, what we had offered as much more national, as I say, topic-based programme support. Organisations were looking for something a bit more agile. They needed a lot more contextual support. We had different challenges in different organisations. And so we have slightly adapted our model in Wales. We have much more regional and local-based support, building those relationships with health boards and trusts, but also nationally coordinating that, so not to lose that aspect. I'm still loading at the moment, so I'm just giving it a second. It does say still waiting that to come through. So one of the aspects we wanted to talk to you about and share with you is our Safe Care partnership. So as I mentioned, coming out of the pandemic, we were looking at what is the new context in Wales, what does recovery look like, particularly around patient safety, but also what are those enabling aspects that builds that quality focused system for health boards and trusts, and how do we share that and support that across Wales. We've partnered with the Institute of Healthcare Improvement on behalf of NHS Wales to create this Safe Care partnership. And what that provides to organisations is, as I mentioned, that nationally coordinated, but also how do we support and understand where are the bright spots. One of the main aspects we lost during the pandemic was actually the connections and learning from health boards and trusts in Wales. There were some routes that were maintained, but a lot of that, there's sharing of learning and lessons learned was being lost. So that is one of the key aspects that the Safe Care partnership brings together. Through that partnership, we started, there's 4 key parts to it. So the aim of the partnership is to focus on how do we build those quality focused learning organisations. That is our long-term vision in supporting health boards and trusts to build that learning approach. And we're doing that through building leadership and coaching and improvement capability within those organisations that is sustainably focused on patient safety. So in Wales, historically, we had largely a focus on patient safety, and separate to improvement capability and continuous improvement that would have been focused on what was traditionally thought of as service redesign. So it's how do we bring those elements together? We spent a large proportion of the early days of the partnership, we are now a year in, with health boards and trusts and the IHI team on site visits, foundational site visits, fantastic, which brought together some of our learning previously from the pandemic, but also a sense check of where are organisations now, what were the challenges that they were facing, and also what were their bright spots, where are the areas that we could share and build that learning across Wales. Those site visits were all based, and our partnership is all based on the framework for safe, reliable and effective care, which looks at some of those enabling aspects. So it looks at leadership, it looks at the culture that enables improvement, as well as the what we would think of the more technical aspects we were traditionally focusing on. So that framework is very similar, and there's so much read across in the essentials. And I've been working with Joe previously as we were coming out of the pandemic to learn a lot about the approach in Scotland, and it's very similar perspective. So using the framework, we were able to visit every health board and trust in Wales and understand what are those challenges, but as I mentioned, what are the bright spots that we can share. That's perfect, thank you very much. So the main bright spots we drew out were actually around staff well-being, and we built some of that learning into our work that works through our Safe Care Collaborative. The challenges that we faced, we learned, and even though they were contextual, there was a very common thread, which was deteriorating patient across the whole continuum. So to Penny's point about the focus on acute, we were very keen that this focused on the whole pathway that stretched out into community, that works with that in-between, so almost the ambulatory phase as well, and that deteriorating patient in its broadest sense, so that we could engage with a widest range of the improvers and patient safety priorities. So following our site visits, we worked with organisations and we co-produced what that partnership would look like. And we have focused on a couple of aspects: leadership and sponsorship, with also coaching support for those improvement projects that were nominated to join the collaborative has been absolutely crucial. So building that wraparound support locally has been absolutely crucial. And I think of those two, that leadership model and that sponsorship model has been the most fundamental. We launched the collaborative just about 6 months ago. And we're having our learning session today, and our agenda's slipped slightly today, which is why unfortunately John can't join you. So I am just down the road from a room of over 200 folks who are sharing their progress and their storyboards at the moment and the learning that they have gained through this. If you could move the slide on once, that would be fantastic. Thank you. So, as I mentioned, that collaborative is a joint work with the Institute for Healthcare Improvement. What we have been keen to focus on is those enabling aspects. We have obviously, there's a lot of evidence-based interventions, and they are well known. We have good improvement hubs and improvement teams across Wales. And so there is a large amount of those technical skills available to teams locally. But the one aspect that we have found working with the teams and working with the organisations, particularly coming out into recovery, is of both cultural and enabling aspects. Within the framework for safe, reliable, effective care, one of the aspects that all of our projects have drawn to is around psychological safety and looking at leadership and how leadership and this work through the improvement can build the psychological safety within their teams, and how that becomes much more cyclical and maintains that and accelerates that progress. If you can go on the next slide, please. So as I mentioned, we have three, if you like, almost clinical work streams. So we have 3 work streams that are focusing on improvement projects within looking at the deterioration in its broadest sense. We have a community work stream, ambulatory and acute. And we have a leadership work stream, which focuses on understanding the connections between leadership and patient safety. We've had some of our bright spots. We had fantastic visible leadership in teams. But when we looked at the system-wide leadership, this was a common aspect that came through from all of our site visits across Wales, that they felt that there was a disconnect. And it's how do we bring those connections back together to build that system, that wider system that enables learning organisations. You can go on to the next slide, please. I've mentioned that one of the key aspects that we're focused on is psychological safety, and this has been drawn, we expected this would be a key area to focus, but all of the teams have designed a piece of work that they are working on around psychological safety. It's connected obviously to their improvements, because you cannot identify and just pick on one aspect. This is about how they work in teamwork and communication, how they are sharing their data, how are they learning, how are they being more transparent. One of the most fantastic things I heard yesterday as we were hearing from teams on the main stage, and this is a significant change in Wales. We had health boards and trusts calling out to each other saying, thank you for sharing your learning over this. We have taken what you have built and we're testing it and adapting it. And to hear that, I don't think we would have heard so dramatically before the pandemic. So it's how do we build that psychological safety, not just within teams, but also across the system, to help enable that learning. Next slide, please. There's one other piece, specific work that we're also doing with organisations, was around our maternity and neonatal teams across Wales. So we have been providing expertise in healthcare improvement, advising and coaching maternity and neonatal leads and champions, across Wales in a diagnostic phase where we were looking similar to the foundational site visits in the Safe Care Partnership, but in much more in-depth and much more contextual. And whilst we did use the framework for safe, reliable and effective care here, we were taking a more appreciative inquiry approach to build up those bright spots across Wales. You can go to the next slide then, please. Thank you. And the next steps in this part is about how do we connect all of those pieces within the maternity neonate. We're developing our patient safety programme, co-producing that with organisations and with the wider system as well. We have a series of system partners, clinical networks, etc. So that will be our next phase, if you like, for our safe care work in Wales. Obviously, with and this is across the whole system, and the whole of the UK, we have just recently, and in Wales, unfortunately, had to announce new escalation levels. There's a majority of our health boards and trusts are now in some form of escalation. And there is real, as you can understand and adjust to in your areas as well, real financial pressures on the system. And the one thread that keeps coming through is where is the time that we are getting to allocate to these improvements. So our focus now is about how do we support organisations and the team specifically in how are you building this into the daily work. And I'm still, I think at the moment, we're at that tipping point where improvements in patient safety and improvement work across the whole of the quality domains is in addition as opposed to embedded within the daily work. So it's how are we moving towards that? And we are looking to learn across the UK in how we can adapt our support and support teams in that space. Next slide, please. So thank you very much, and apologies you had myself instead of our director John. We are looking forward to linking with you again. It would be fantastic to be in Scotland actually at a future event and to see and learn with you. So thank you very much, and I'll hand back to the chair.
Thank you very much, Dom, and thank you very much to all of our speakers. So now this is your chance. You've heard some great inspirational pieces of learning from our colleagues. You've heard some really, we've heard that people speak about the challenges that are sitting there in our system as well. So over to you. I think we're going to take questions first of all from our virtual colleagues. So Jo?
Yeah, sure, thank you. So we had a question from online. I guess it's applicable for both of our speakers, but it's in relation to keeping that focus on safety. So how do we keep that focus on safety given financial and operational pressures? And how do we respond to some of those challenges that come to us when people say that we perhaps can't afford to focus on safety? And how do we respond to that? So I guess for both speakers.
Can I go across the speakers? Maybe Penny, can I come to you first and then I'll invite Dom, and then perhaps Jo, you might want to make some other comments.
Yeah, yes, thank you. Happy to. I mean, it's been a theme through this morning, and it would be tempting, but I won't offer glib answers around the overriding priority of safety. I think we need to be thinking about how we foreground some of the ways in which we can maintain and keep a different, make an impact through safety that integrates with other objectives and can be done within that kind of pressured environment. I shared the kind of book from Charles Vincent and Renee Alberti. One of the things that Renee kind of talks about particularly is the sort of different types of risk environment and how often we look to very highly controlled environments like nuclear power or like the airline industry. Whereas his interest is about how do people manage risk in moments of kind of, crisis or very much more fluid situations. And, there is a lot of learning that we took from the COVID period about actually how that rapid sensing, problem solving ethos of improvement and the kind of communication skills that have emerged through safety science are absolutely the things that are critical to you when you're under the greatest pressure. And so it might be worth drawing particular attention to those things and kind of building out from there if that's where your organisation is at. I mean, recognise then taking a slightly longer view, that challenging question about, you know, can we afford a focus on safety? I guess even though it may feel uncomfortable to kind of lean into that debate, as opposed to saying we have to focus on safety as an overriding priority, I guess there are ways in which safety connects to financial and delivery objectives. So, you know, there's a direct reduction in harms. You know, if you reduce harm, then you're reducing failure demand, you're reducing length of stay potentially, you're reducing unnecessary referrals. So kind of helping to draw attention to the ways in which these objectives are kind of takes in the same direction. And also a few people have talked this morning about the importance of staff morale and engagement. You know, so much of the financial pressures and workforce pressures, they're about, you know, people's time and their discretionary effort. And, you know, with the history of kind of sort of moral injury that's happened through the pandemic, there's an argument to actually keep a focus on safety, also in order to create space to support staff resilience and morale. Yeah, so I don't know, interested to hear your reflections, Dom.
Thanks, Dom.
Yeah, completely agree, Penny. I think, and if we look at safety as part of that broader quality piece, you know, driving down costs won't drive up quality, but driving up quality will drive down costs. Now there is this is I think is a leadership challenge and a leadership choice. We have to maintain that focus, that longer term vision on what we're trying to achieve. And I understand obviously with the short term pressures, but there is that choice. How do we continue to focus that long term vision? Because we know that if we focus on the short term, then actually over time, this will cost the system a lot more.
Yeah, thanks. Jo, anything you want to add to that?
Test out the microphone. I think from my perspective, I completely echo what Dom and Penny were saying there, and thinking back to all aspects of quality and all of those domains. I'm thoughtful as improvers and as a leader of a national programme, how myself and the teams can do more to be able to evidence that impact beyond the reduction of harm, and really be able to demonstrate all aspects of those domains. And I immediately went back to work that some in the room will know around value management and the methodology that we use within, which actually uses a range of different tools to understand not just in relation to the quality, but all aspects of within that quality. And that aligns to work that is already happening in Scotland around value-based healthcare. And I think we've got a much closer link to make across those pieces of work to really be able to answer some of those questions and demonstrate the broader quality impacts that we make.
Yeah, thanks very much. Simon?
Thank you very much. I'm really glad this question's been asked because it's a very important one. So I'm just going to offer a slightly different perspective and hopefully something that's a practical help as well. So a few years ago, Healthcare Improvement Scotland did some very detailed and rigorous work looking back at when things have gone badly wrong in systems to see what were the signals that were there before to tell you that conditions were unsafe and something was going to go wrong. And we published this, and it's been embedded by a number of boards and others, but we use it as part of our sharing intelligence work. And I'll just quickly rattle through the key things that we found, if they were not in the ideal place and going wrong, were more likely to make your system be unsafe and a significant failure within your system. So they were leadership, so gaps in leadership, problems with leadership, positions not being filled, etc. There were problems in culture, which I think we'll all know, but signals coming up that there were problems in culture. There was evidence that the governance systems weren't working right, so things being missed, or a problem just getting to grips with all the things you need to do around governance, like adverse event reviews and so on. Pressures on finances, pressures on workforce in terms of lack of availability, etc. Evidence of disengagement of your clinical workforce in particular, and signals to say that clinical and care performance weren't great. And then rather than just leave them as big headings, we actually gave very specific things as to here's where you'd look for the data. So I think if you take a step back to the situation at the minute, I think despite everybody's best efforts, we know that those things are all probably under pressure at the moment in all organizations. And conversely, just as this system was designed to spot problems, working on these areas to try and do the best that everyone can will increase safety. So I think I would perhaps change the narrative slightly and say that in working on making these as robust as they can and supporting them, people are working on safety. It's not only about what we're doing, but actually if people want to see the relevance or draw a line to why do these things impact on safety, the model we've got and the research behind it provides quite a specific and evidence-based way of looking at it. And I'm not blowing his trumpet here. I think that model's just been adopted by NHS England as part of their sharing intelligence system. And as I say, I know a number of boards in Scotland have embedded it into their clinical governance. So if you need to know more about that, grab me or one of the others in the break. Thanks very much.
Thank you, colleagues. Jo, do we have another question online? Then I'll come into the room. Thank you.
Okay, great. Yeah, it's from our clinical lead, Dr. Lindsay Still, who's a neonatologist supporting the work that we're leading. And I guess, Dom, particularly, you spoke about one of the themes being around staff well-being that came out from your work. And Lindsay's question is around how do we support and lift staff morale in these times, and how do we support staff at the moment?
Thanks, and thanks, Lindsay. And what I can see from the improvement work that we're doing through the Safe Care Collaborative is how those teams are feeling empowered, that they can make small changes to their environment, to their approaches to person-centered care, and to see that feedback and see how those teams are working together. That is helping to maintain or maybe lift some of that staff morale, but it does take time, and this is that really fine balance where teams haven't necessarily been given that support and that time and that leadership space as well. That's where we're really struggling. There are some fantastic examples, and it's got to be a small improvement at a time. We have got some organisations that are focusing largely, they're developing an overarching culture programme for the whole of the organisation. But I think from my experience working within the collaborative and with these teams, it's how are we building that at the team level and connecting that together, as opposed to trying to design something for a whole organisation.
Thank you very much. Thank you. Penny, did you want to add to that?
Yeah, I mean, it's obviously kind of support staff morale if they feel like they're part of a team, organisational system that has a focus on the things that are important to them, and clearly kind of safety is, critically important to that. And just building on the conversations we were having earlier, that can be very quickly eroded if there is a sense that there's a disconnect within the organisation, so that it's not an authentic, kind of holistic and honest approach to the goals that the organisation is trying to achieve. So for me, that underscores the importance of these honest and holistic views of how we're thinking about safety alongside other objectives. And as Simon says, the actual enabling conditions are common to a number of ways in which organisations can find themselves on the wrong track. I guess there is the practice of being able to solve the problems around you does give a morale boost. So we can make the case for investing time in that through the staff benefits, to my mind, even if the actual impact for patients comes a little bit later. I would also draw out that actually the opportunity to learn and collaborate with others who are, providing services along the pathway. That's an aspect of improvement work that we need to make time for. There is a bit of a risk that there's so many staff changes and changes to pathways and processes, as part of the pandemic, at least in England. Actually, a lot of those relationships and that sense of belief that the people who are upstream and downstream in the pathway are all sharing a similar sense of commitment to good quality care and patient safety, and just a little bit of a sense that some of that trust might have eroded if we have a bit less time to kind of collaborate and problem solve together with other people in other parts of services. So to my mind, improvement can offer quite time efficient ways of doing that collaboration that helps people feel like they're part of one team pulling in the same direction, which I think is also important to staff morale.
Thank you. Let's come into the room. Do we have questions from colleagues in the room? Yeah, thanks. And please feel free to move the mics.
It's more of a reflection than a question, but it might lead to a question. So part of my role is leading the delivery of the acute adult programme, and I think recently what we've noticed from teams, boards, hospitals who are showing improvement, some of which Jo showed earlier, are that the one intervention or the one or two interventions that make a difference are not the things at the moment. And what we're hearing is that it's having a constant conversation about issues, problems, things that they want to make better, but also that sort of visible leadership. And I guess for us as a national team, but also for the hospitals and the boards, it's how we pull out those enablers so that others can see that these are actual things that help you get to where you want to be. So often we'll say to teams, what are the things that you did? And they said, well, we talk about it all the time. It's in every meeting. It's in every daily conversation. It's in our safety brief in the morning. And they sort of see that as the softer side of improvement. So I guess the question probably for the room and for others is, how do we get that up the agenda to say that actually if the conditions are not right for improvement, then having one intervention or two intervention, we don't even get to that point?
Yeah, no, that's a helpful challenge to the room. Anybody want to come back and comment on that? Or do any of our speakers want to make a comment on that?
It's a really interesting reflection. Maybe I could kick off. I mean, I think there might be something about what we pay attention to when we're measuring and talking about the impact of the improvement work we're doing. I remember when I was in my last job before the foundation in East London, we had a range of safety interventions, but we saw a change in kind of, you know, overall measurement of mortality and other kind of top level safety indicators that seemed disproportionate to the specific interventions we were making. And, you know, that might have just been a sort of data artifact, but the conversation was that actually it wasn't just the specific changes you were making to pathways. Actually, there is a broader cultural change that happens around and through that work on specific interventions. And that it's not just that there's context related work and then there's the work that you might be doing on falls or, you know, cardiac arrest. It's that through doing specific work, you are also contributing to a wider culture around safety in a way that I think, you know, the Health Foundation's evaluations and local evaluations sometimes hasn't been sufficiently sensitive to. And so you end up with this disconnect where people are being very positive about the impact, even though that may not always be reflected in the specific numbers.
Yeah, no, thank you. And I think actually, Jo, you touched on that earlier, that piece around having the framework and creating the rhythm, that it is just how we do things. So actually it becomes more part of our norm again, where actually we haven't been there always in the last few years. Any other comments or questions in and around this, Jo? And then colleague on this table, thank you.
Thanks. And I think just to build on that, and I wanted to come back, Penny, we've just seen in that word cloud from colleagues here today that they're here to learn. And I'm thinking back to the work that you published last year with Virginia Mason in terms of the cultures of continuous learning. It was brilliant to see you got QMS up there with the learning system right at the centre of that. I wonder whether you could share more about what you learned through that work with Virginia Mason in the realms of that continuous learning, because that feels to me like it builds on Claire's points, but it's at the centre of everything we're trying to do.
Yeah, I mean, there was, you know, no hesitation in drawing attention to the work that you've been doing around learning, as there's been, you know, massive interest in this as part of the, you know, the work that has been published following on from the Virginia Mason work. We also published some work around learning healthcare systems, which articulates another way in which this idea of having systematic approaches to learning is kind of really taking root now and gathering quite a lot of interest, you know, internationally and certainly across England as well as elsewhere. I think the key for me is that there is a a kind of organic social network component to learning that needs to be combined with the really kind of more systematic and directed learning that like draws on data and comparison and kind of keeps us rooted in specific focus of learning. The work of the Virginia Mason Initiative Evaluation showed the importance of, in particular, perhaps those more fluid social connections. We see that through Q and Q's evaluation all the time, that actually the extent to which people are able to connect freely and flexibly and share kind of practical know-how actually contributes and is a good indicator of the wider effectiveness of the kind of organisation as a whole. Forgive me, I kind of latched onto one particular finding from that evaluation, which has felt particularly pertinent perhaps to this conversation here. I will try and dig out and put in the chat the kind of summary of the evaluation, because there's a few different connection points to the themes of today. I don't know, Jo, if there were particular things in your mind you wanted to draw out.
No, I think it was just really being able to call out that it's an absolute central part to enabling all the improvement work that the organisation itself values, prioritise and has a focus on continuous learning at every level within the system, both strategically and operationally.
Yeah, and learning, I mean, in a safety context, learning is often kind of focused on incidents and safety reporting, and it's how do we connect all we've learned from that safety domain to some of the broader things that we're learning about improvement and collaboration. It's a really exciting space, I think.
Thank you. Can I invite colleague, would you mind introducing yourself to the room as well? Thank you.
Okay, that's working. Thank you. Good morning. I'm Maureen Stevenson. I've worked in the field of quality and patient safety for at least 20 years and been involved with Q when it was set up and with the Scottish Patient Safety Programme and various other initiatives. What I really wanted to ask the panel was that in light of the Lucy Letby case, there is a sense that our boards and our executives and our government are pulling us back to a place where we're trying to root out bad apples within our system. And we've come an awful long way over 20 odd years to where we are now looking for systemic learning and that anticipatory piece that everybody's been talking about. I would really value your reflections on how we moderate that, guard against it, and move forward in a really positive way that provides the assurance, I suppose, to the public that actually the NHS does not harbour people with criminal intent in any more than it does across society in general.
Really perfect question, thank you. Penny, Dom?
Would you like me to go first, as it's a
Thanks, Penny.
thing? Yeah, I mean, yeah, very tragic, unfortunate on so many levels. I guess thinking about the pandemic and sad to say the sort of inevitability of kind of crises of care that we're going to form a backdrop to our conversations about safety. I must admit, I hadn't necessarily anticipated that you know, this would be the one that I think will continue to run. And, you know, in a way, it's almost drawing attention away from some of the other forms of harm, which are much more kind of familiar and kind of sadly prevalent in our health services. So it's almost like ultra special cause forms of harm, and feels just particularly depressing that, you know, for understandable reasons, that is likely to kind of run, you know, at least within England. I don't know whether that will, you know, spread throughout the UK, and will end up, I would suggest, you know, is going to end up prompting a whole set of actions that may very easily draw us away from some of the things that safety science might suggest we prioritise. That said, I mean, this has been part of a lot of conversations I've been part of over the last few weeks, and I think people are still trying to make sense of it and try and find the kind of positive agenda and way forward. I think, you know, there are some clear themes that are emerging from that particular situation that do resonate with other reviews. I mean, Q was set up partly in response to the Berwick review, looking at you know, the responses, the problems that happened in mid-staffs, and some of the patterns that are coming out there are some similarities in terms of the enabling kind of challenges in organisations that can lead to examples of harm. So I guess back to Simon's point, if there's a way in which we can help keep the focus on some of the things that are guided by the evidence more generally in terms of the enabling conditions that will guard us against all forms of harm, then I hope that might help us kind of keep on track and maintain a kind of positive and useful set of learning from this. Yeah, I mean, really interested in other people's perspective. I'm conscious we're at the early stages of probably of sense-making conversations, so I may be kind of cutting across how others are thinking about this. Dom, would love to hear your views.
Yeah, thanks. So Dom, I'll just invite some brief comments. Unfortunately, because of time, I'll go to Dom, then to Simon, and then we'll bring this session to a close. So Dom, then Simon, thank you.
Yeah, completely agree with Penny. I think it is about how do we look at what are those common themes that come out and the lessons learned, but looking at it in its broadest sense, because this is this is a very, very special cause. I think one of the aspects that we need to consider is how we use as lever, how do we use this improvement community? So, you know, you've got the whole of the UK. How do we build that connection further so we can support and make so those voices, it's not just individual boards that are trying to support that focus on system as opposed to individual, but actually that's a national and across, as I say, Great Britain, Ireland, etc.
Thank you, Simon.
Right, thanks very much. I think I'm really glad the question was asked because I think it's very important. It is, as a case, it is a complete aberration in one sense, in that it's very, very, very unusual for women to kill, full stop, and incredibly unusual for women to kill children. My experience of the nursing profession over 27 years has been entirely different, not least during the pandemic, where I saw nurses risking their own lives to make sure that people with COVID, before we had vaccination and treatment and everything else, they would go in to the rooms with people with COVID and sit with them and make sure they didn't die alone. And I found that, I'll never forget that. And that to me is what nursing, it's an example of what nursing is all about and the ethos of it. So there is a danger that this goes down a rabbit hole, that it's all about nursing and so on. But I think there's an inevitability we have to deal with this. And I think it's highly unlikely that this individual will explain what her motives were in the same way that Shipman and the others didn't. But I think the lesson for us perhaps to focus on is, if you were motivated to kill people, I'm afraid you'd recognize that healthcare in some ways is a place where if people die, it's not always immediately picked up as criminality. So there is a risk there. So I think the public does have a right to say how we're protecting that. But more importantly, if you're planning this through, you wouldn't choose a unit that had exemplary safety culture, extremely good systems for monitoring and control, and an environment where if people had concerns, they would speak up without hesitation. So I'm saying that cautiously because I don't know what the situation was in Chester. I know a lot's been reported, and Penny might have more insights into this, or even Dom, because it's near Wales. But if you think about this logically, I'm afraid you'd probably target somewhere that had weaker systems like that. So I think it's certainly not all about that. But I think one of the links to this case is, how do we make sure that the safety culture and the safeguards are so strong that those individuals, A, wouldn't go there, and B, if they were to do anything to harm patients, that would be spotted very immediately. And I think that draws us back to the kind of culture and the systems that we want. So it's an excellent question. Thank you for asking it.
Yeah, no, thank you very much. And In just summing up this session, I'd just like to go back and thank all of our presenters. So thank you to Minister Minto, to Joe, to Dom, to Penny, and also to all of you who have put forward some really interesting questions. We could discuss a number of these topics for days, but I think there's a few elements that really come up for me that have set out, I guess, the key elements. The elements of really the value, what is the value of safety and quality at its core, and indeed the culture that's associated with it. I think we began this morning with Minister Minto very helpfully framing for us the voice and the desire to amplify the lived experience piece, the patient voice, and of course the important role of the Patient Safety Commissioner. And also a really nice place to start with the thanks to all of you, everyone who's participating today, for all of the work that's happened and her encouragement to continue along this really important path. I think to Joe, to Penny and to Dom, I think you've raised some really, really helpful points for us, and I think there'll be much mulling over of the points that have been made and a lot of consideration. In terms of that, what can we change? We are in a time of a significant system change, and how do we bring all the learning, the elements that you talked about, Joe, in terms of framework and scrutiny and rhythm? How do we bring that piece? The blend, which I think is a really, really important piece that we've been hearing threaded through all of this, the blend of technical and indeed, as you said, the relational piece. And I think through all of this, the improvement elements that are hope. What is the link then, of course, to the value-based healthcare that we're just at the foothills of, and what will that mean? I think, Penny, also you brought out a few really important elements in and around that enabling future models and thinking about the system-wide approach. And of course, I think that is I guess, where I think many of us hope the solutions lie, in this very challenging landscape of financial challenge, of recruitment and retention challenges, and of course moving forward into how do we start to redesign and reform our system in a safe and effective way. And at the core, again, Dom, you touched on the quality elements and starting from the right place. So drive everything from quality, and we'll come to good if we start at the other end. We know where that lands us. And of course, wrapped around all of that culture and capability. It was lovely to hear the voices come through from everyone, that piece talking about evidence-based, all these positive elements about it feeling good, about the sense of learning and family. And I think Eddie's other comment around critical thinking, being able to be empowered with having critical thinking in complex environments that change every day. So much to talk about. I'm sure there'll be a lot more discussion as the day goes on over coffee and into your further sessions. I'm sorry we're just running a little bit late, but I'll hand over to others maybe just to give a little bit of the logistics of the breakout sessions. Thank you. Thanks very much for your participation.
Thank you, Jan, for that fantastic summary. So you are now moving to coffee, and then from that 12 o'clock breakout session, so it's a quick grab a cup and get to your room. You will have the information on your name badge, and the people with the yellow lanyards will be able to direct you to the correct room that you need to go to. It is then lunch. And just a reminder that those people who are attending the paediatric launch this afternoon, get to the front of the queue, because your session starts at 1:30 and everybody else's session starts at 2 o'clock. So you need to get your lunch in first. We'll see you later.